Well, hi everyone. Welcome to Seattle and to WAGO. What a great morning. And we're going to have a great lunch and then have the afternoon to enjoy this beautiful city. I'm very happy to be invited back. Some of you know this, but many of you are too young. Like you're born after I became a doctor, but I actually went to medical school here in Seattle. And my husband was a Navy submarine officer in Bangor. So this place actually is very special to us. So I'm really excited to be here. And I'm even more excited to be here with my friends doing this industry-sponsored symposium, which I think is going to be really great. It's case-based, so I think you're going to enjoy this, and we'll have time for questions. I guess I don't need my glasses. So this is the title. Welcoming you now. These are our expert panel. So I'm Kathleen Moore. I've already introduced myself. I'm currently the deputy director at the Stevenson Cancer Center in Oklahoma City. And I would like our panelists to introduce themselves, and we'll just go from my left to right. Dr. Reimel.
Hi, I'm BJ Reimel. I'm a gynecologic oncologist at Cedars-Sinai Medical Center in Los Angeles, and I'm the medical director of the Cancer Clinical Trials Office there, and I'm very excited to be here.
Hi, Debbie Richardson, GYN oncologist at the Stevenson Cancer Center. I am the section chief there and Katie's partner and do both phase 1 and late phase clinical trials.
Hi, I'm Catherine Fu, GYN oncologist at UCSF. I'm a director of basic and translational research there, and really excited to spend some time with you all today.
All right. These are our disclosures. I'll just leave them up for a second or so you can see those, which is important, and they'll be available to you to look at with the slides later. And this is our agenda. So there's going to be 3 components to this industry-sponsored symposium today. The first, we're going to start off kind of going over what the NCCN guidelines are when we're taking care of patients with recurrent ovarian cancer. Then we're going to talk a little bit around toxicity, specifically about mirvetuximab. And then we're going to end off really talking about developmental therapeutics in the recurrent space. And we're going to precede each of these with a case that kind of illustrates some of the controversies and challenges when selecting a therapy for our patients with recurrent ovarian cancer. These are the learning objectives, and I'm not going to read them to you, but basically so that you know, I know we have a lot of learners at WAGO, and so it's a lot of new things. So we want you to know what the National Comprehensive Cancer Network or the NCCN guidelines are. We can talk a little bit about how they come to be and what they mean. Just talk a little bit about how you construct sequencing and incorporation of antibody drug conjugates. We have 2 currently FDA approved for ovarian cancer, more to come, and how you think about them in your patient with recurrent disease, really assessing the role of PARP inhibitors. And then we'll talk quite a bit around some toxicity management, mainly ocular and pneumonitis, and answer questions at the end. So without further ado, we'll start with our first case. So this is a case you probably have all seen a case just like this. She was 75 at the time she was first diagnosed in 2020 with stage 4 high-grade endometrioid ovarian cancer. She was taken to the operating room, had a laparoscopy, and had a Fogarty score that was quite high. I actually didn't put it on the slide, but was deemed unresectable, and so treated with neoadjuvant chemotherapy for 3 cycles, and then had a very successful interval cytoreduction to no gross residual, followed by 3 additional cycles of paclitaxel and carboplatin. Was BRCA wild type, but HRD, we thought. We didn't actually have testing at that point, but she'd responded really beautiful to her therapy, and so felt that niraparib maintenance was a good option for her in the maintenance setting. And so she was placed on this for a year, at which point she had radiographic progression. So she's platinum sensitive by virtue of the fact that she has a 12-month platinum-free interval, and was reinitiated with a platinum-based therapy, carboplatin and pegylated liposomal doxorubicin, or I'll call that PLD for the rest of this day, and bevacizumab. And unfortunately, after 3 cycles at her first disease imaging, she had progression. So now we would deem her platinum resistant. So now she's kind of come back, and I'll turn this to my panel. She's come back for her CT review, and unfortunately she's come back, she's sitting in your office. She's a CT scan with new peritoneal disease, doesn't have a bowel obstruction, doesn't have ascites, enlarged lymph nodes, good performance status. And so just to turn it over to my panel, and I'll go back to this slide. When you're thinking about two questions, when you're thinking about designating a tumor as platinum resistant, what are you thinking about? What are you thinking about for kind of options? And what else? She's got a CT scan. What other testing do you want on her so you can start thinking about her next option? So I'll just open it up to the panel.
I'll start. I mean, I would want next generation sequencing done on the tumor to know if we have any targeted therapy. And then I'd like to know, did she progress on the platinum, which I believe on this case she did, but otherwise, how long has it been? Because it's a continuum from their last platinum. And then also when they've had prior PARP, did they progress on the PARP or after a PARP-free interval as well?
Any other thoughts? Anything else you guys would want? You said next generation sequencing. Anything else you'd want ordered?
Oh, so I mean, sorry, when I order my next generation sequencing panel, the company I use also does IHC for things like HER2 and is going to give me the folate receptor alpha as well. So, and I'm sure any new biomarkers that are to come.
Yeah. And then when we think about platinum resistant, and again, I'm showing my age, but we just said, okay, greater than less than 6 months, platinum resistant. I don't use a platinum anymore. Less than or greater than 6 months, I do use a platinum again, which, I think we can agree is probably overly simplistic. And this is sort of an attempt to start breaking it down. Like what really goes into is this what you think about all of these? Are there other things that you think about when you're classifying a tumor in terms of use of further platinum or not? Dr. Reimel.
So I agree with Dr. Richardson. It depends on how long it took. What their response was, this patient progressed on platinum, so I'm really not going to go back to it. But somebody, for example, that might have had a response, either a partial or complete response to therapy, I might be more inclined to return to it, even if the interval isn't that long. If I don't feel like I have other really good options, the performance status always makes a difference. Platinum's kind of hard to take if they've had a lot of bone marrow toxicity. There are just other things I like to think about.
Yeah.
I agree.
Yep. So additional testing, we wanted next generation sequencing. So this is the testing that was sent on this patient. And so what we're just highlighting here are not necessarily things that are abnormal, but what are you looking for? Like when you get your next generation sequencing back, Dr. Fu, like what are you looking for? What are you hoping to find, when you're looking for targets?
Definitely. I mean, I think we know for BRCA, she had germline testing, so we already know she's wild type, but you are maybe hoping that maybe she might have a somatic mutation, and even though she was negative for germline mutation. And then looking for one like mismatch repair, we know that, MSI is very rare in ovarian cancer, high tumors, but at the same time, we're always maybe hoping she has endometrioid. So there's definitely a potential for that with that histology. And then HER2 and folate receptor expression for sure, is also on my mind. For trials that we have through the NRG and other sponsored trials, we're also looking for ARID1A, for example, CCNE1, and then folate receptor we'll talk about.
Yeah. Yeah. So, I mean, these should be different colors, so I apologize, but for clinical trials, although we have mirvetuximab approved, there's other folates. So we have those listed both as clinical trial options and standard of care options, things that we're looking for, along with ARID1A and others. And when we talk about the NCCN, when Dr. Richardson takes you through that, she'll take you through some of the other biomarkers that are rare, but things you want to have on your brain to catch. And this is just a continuation of her report. This happens to be a KRAS report, but we look for KRAS. She does not have a KRAS. And we'll talk about this a little bit. There is finally a TP53 mutation that can be targeted and in clinical trials. So there is a mutation we're looking for, which she does not have. And so this is her report. So this is sort of what goes into the chart now. She's biomarker BRCA wild type. She is HRD negative. That was on this test as well. And folate receptor alpha medium, not high. So from a standard of care, we didn't find any biomarkers that linked any currently available standard of care FDA approved drugs. But from an NCCN standpoint, she does have folate receptor alpha expression, which links to use of mirvetuximab and bevacizumab. And from trials, actually, other than the folate, we don't really have any other kind of clear mutational links for this particular patient. And so for considerations for therapy for her, This is something again to the panel. She's 2 prior lines. She's had prior bevacizumab. She progressed on it. She's progressed on a platinum. She's progressed on a PARP. You know, what are your considerations for therapy for her with this kind of biomarker
So it's-
finding?
Seems pretty obvious that she'd be a good candidate for mirvetuximab plus bevacizumab. We can reuse bevacizumab. We feel pretty confident about that. We don't have a biomarker to direct us that it wouldn't work, so that's not unreasonable to continue.
Yeah. Any other thoughts for her?
I mean, I think the other option would be weekly paclitaxel with Bev. I would say those are our 2 most active regimens, and it would go into, some patient factors as well. For example, is she able? How far does she live from the center? Is she able to come in weekly? Does she have residual paresthesias from her upfront paclitaxel, hair loss? So just kind of going through like we normally do, side effect profile and efficacy, and then kind of making a shared decision.
Yep. So I'm gonna just show you this because Dr. Richardson's whole talk is on the NCCN. So this is just to kind of review what the NCCN guidelines say for platinum-resistant disease in terms of preferred regimens. They always say, the best option is a clinical trial, and sometimes we do have to consider best supportive care, and this is where shared decision-making is quite important. And then the other recommended regimens, we're going to be going through many of these during this talk today, but you can just see the highlighted mirvetuximab with bevacizumab and folate receptor alpha expressing tumors. It doesn't say high. So this does give us a window to use this in patients who are like 65% positive and don't quite meet that high cut point. And this is now a 2A recommendation. Why we're having this whole symposium is really to talk about the high unmet need, which is platinum-resistant ovarian cancer. The highest unmet need is screening, which I can't talk about today, but hopefully someday we'll just prevent this thing. But until that time, this is really where, once a patient's tumor becomes resistant to platinum, they just enter this kind of series of therapies with standard chemotherapies. With each line of therapy, the expectation of response gets dismally poor, unfortunately, especially once you're out of the weekly paclitaxel range, and the duration of response and median progression-free survivals just become, almost placebo-like. And so this really is an area of high unmet need. From a clinical trials world, and we can maybe talk about this in the discussion, we are trying to really redefine what we mean by platinum resistant, bringing in some of those elements that we talked about, histology. Is it progression on a platinum or 5 months later? Those are different tumors, the molecular characteristics, et cetera, to better define a population of patients who should be treated with different agents. This is hard to do from a regulatory standpoint where in the US and in Europe, they're used to certain benchmarks, but we are trying to individualize this definition a little bit more. But clinically, we can start to do this just in our practices with the information that we have available. We can talk a little bit about that as we go. Our standard of care, we're going to see this slide several times. Now our 2 medications, the first is chemo plus bevacizumab with Aurelia, and I'll let Dr. Richardson take you through this. For this particular case, though, Dr. Richardson, you said you might give her a weekly paclitaxel and bevacizumab. Does it really even apply? And I'll ask you just to maybe speak to that in your talk. Does it even apply to this case where she had prior bevacizumab? And then we might want to talk a little bit about how if you're going to use an Aurelia regimen, what backbone do you pick? Are they all equivalent? Does it matter? From an efficacy standpoint. So these are the things we'll get to in our talk today. But really, I think you've already heard us say, and I think this is one of the things, again, we have a lot of learners in the room who may be used to clinical trials with investigator choice of pegylated liposomal doxorubicin, topotecan, and weekly paclitaxel. We kind of lump them all together. So you may think that you can just pick one and they're all equivalent. And what is coming out of recent phase 3 studies, and they're listed here, and you have the international PI sitting at the far right of this table for the middle trial. What we have learned is that weekly paclitaxel is a very different medication from pegylated liposomal doxorubicin, GEM, or topo in terms of efficacy and response. And so this is something we really want to make sure everyone is aware of. Because it is a distinctly different agent from an efficacy standpoint. And then now we have mirvetuximab with or without bevacizumab is an FDA-approved option as monotherapy at least. And we all talked about, this being an option for her, even though she's had bevacizumab referencing the forward 2 data that I think we'll go through in a little more detail today. So just to round out the case, and then I'm going to turn it over to Dr. Richardson to go through the NCCN for this particular patient, just like our panel said. She was offered standard of care. We always offer standard of care trial. She was offered standard of care, weekly paclitaxel. This predated the NCCN availability of MIRV-BEV, so it actually wasn't an option for her. So we offered her weekly paclitaxel versus clinical trial, and she actually went on a clinical trial of raludotatug and is still on that trial currently, doing quite well. So we can talk about that ADC too. But that's what she went on and remains on therapy doing fine. So the takeaways from this case are really multiple parameters go into treatment decisions in the platinum resistant setting, and is not just greater than less than 6 months anymore. We really want to emphasize the importance of tissue and having tissue so that we can do up-to-date biomarkers. There's a number of these medications. We're going to talk about a teeny tiny number of them today, but there's a number of biomarker targeted medications coming, and we're going to have to keep adding the biomarkers to our patients' portfolios, as these medications come into trials and into FDA approval. So having tissue and being comfortable giving biopsies and really explaining that to our patients is really critical in a way that it really has never been in the past. And then apart from clinical trials, we have 2 very active drugs in the platinum resistant setting. You're going to hear about them today. Weekly paclitaxel, which is not a new drug, but I think we should just revisit it a little. And then mirvetuximab, not together, but separately, are probably our 2 most active medications in this setting. And then it just would be remiss to not say that shared decision-making with our patients goes into treatment decisions and selection in this setting is just as important as your KERAS test. So with that, I'm going to turn it over to Dr. Richardson and ask her to take us through the NCCN. Thanks.
Thank you, Dr. Moore. Okay, so I think everybody's familiar with this, but I just wanted to highlight, I think it starts right with germline testing. Number 1, we have to identify those patients who have genetic mutations, both for themselves and for their families. So again, to Dr. Moore's point, we can identify those previvors and hopefully not ever have to have them as our patients. But then if they do not harbor BRCA1 or 2 mutation, then in general, recommendation is to go to tumor testing, especially for advanced or recurrent ovary cancer. And that's pretty standard, whether you're looking at NCCN guidelines, ASCO, or SGO. They're all slightly a little bit different, but they're all getting at the same thing. And so I think, the ovarian cancer story starts then when somebody's diagnosed. The majority of our patients are unfortunately going to be advanced stage. We have to make a decision when we're first meeting them. We've decided, okay, we're going to do our germline testing, and then we've got to make a decision of neoadjuvant chemotherapy versus upfront debulking. Of course, they're going to get a combination of chemo and surgery almost all of the time. And then you make that decision of whether you're going to give bevacizumab or not. And then when you get to the end, then it's maintenance. If you've given bev during the chemo, then you're going to, in general, continue the bevacizumab, as long as there's no contraindication. But that's where your germline testing and your tumor testing is going to come into play, because if the patient is homologous recombination deficient and you've started BEV, you can add a PARP inhibitor to that. If you've started BEV and they are HRD test negative, then you would just continue the BEV. However, if you haven't given BEV, then you have PARP as an option, even if they're HRD test negative. And you've just got to keep in mind, we're going to go through a little bit with the NCCN guidelines, but the PARP inhibitors as maintenance in platinum sensitive have been pulled unless the patient has a BRCA1 or 2 mutation, whether that's a germline or tumor, depending on which PARP we're talking about. But, I used to think, well, I'll just save it. I'll give my PARP for maintenance in the platinum sensitive setting if they're HRD test negative. We don't have that as an option anymore. So I do sometimes bench that against what's their platinum response, especially if you've given neoadjuvant and they've had a tremendous response. And then I send my tissue at the time of interbulking and they tell me they're HRD test negative. I'm like, well, everything is showing that they're pretty sensitive to platinum. And so I do consider PARPs, especially in those patients. So these are NCCN guidelines then for platinum sensitive ovarian cancer. I think everybody's aware in general, it's going to be a platinum doublet with or without bevacizumab. And then GemCis is also listed, not with bev, but I think you could give it as well, especially if there's a reason why you're switching. They do list bevacizumab alone, which I do think is interesting. And just so, when we're discussing NCCN guidelines in general, If it doesn't say it, it's a 2A. And 2A means high quality or intermediate level quality evidence and consensus of about 85%. Whereas if there's a category 1, that means it's unanimous and high quality data. Okay, so some things do get level 1 evidence. Most is 2A, and then there are 2B and 3, and we'll see that. So these are the other recommended regimens. And interestingly, under targeted therapy, there are still PARP inhibitors listed. So category 3 means that there is serious disagreement. It doesn't matter what the level of evidence is. I think it's very interesting that they're still on here. I suspect they're still on here so that if there is a patient, we were having a conversation yesterday and Dr. Reimel shared a story of a patient of hers that is really not a candidate for chemo, but has a BRCA mutation and therefore is on a PARP as treatment because that's really her only treatment option. So I suspect that is why these still exist, because the FDA did pool the approvals for PARPs, both, like I said, in the platinum sensitive, but also for the treatment. So there were some studies that were done, but when NOVA resulted and when Ariel 3 resulted, the FDA decided as far as platinum sensitive maintenance that there may be a detriment to overall survival, even though the confidence intervals cross 1. And these trials were not powered for OS, they were powered for PFS. So it's interesting that they pulled it, but they did pull it, from that label. And then in addition with other follow-up long time, there is some concern about overall survival with PARPs as treatment. So just something to kind of keep in mind as you're looking at these. And then, we have our things on the right. So this is where your tumor testing can come in. I'm still waiting to see some of these options, like for example, NTRK or RET. So an NTRK fusion, that's 0.3% of all ovarian cancer. But if you have one, you want to treat the patient with that targeted therapy. Those response rates are 75% or higher when you use those target therapies. And a RET fusion is about 0.13% in ovarian cancer. But again, those drugs work very well. And then this is our PROC. So in general, it's going to be single agent chemotherapy. So Dr. Moore kind of reminded everybody about Aurelia. Just to remind you, though, that was only 1 to 2 priors, and those patients had not had prior bevacizumab, and that's what she's getting at when I said I'd give the patient weekly Taxol Bev. But I would say those other 3 trials that she showed, the more recent things of OVAL and Accelerate, et cetera, those patients have had prior bevacizumab, and we do have data showing that you can use Bev after Bev, that the resistance mechanism is very different than it is to chemotherapy. And so there is some rationale for continuing bevacizumab, even when a patient has progressed. It seems that every time we give bevacizumab with chemo, it does increase the response rate, right? So Taxol by itself in Aurelia was 30% response rate. With the Taxol with the bevacizumab was a 50% response rate. So, but you have some other options as well. Always, you should be thinking about clinical trials. That's what we do for a living, all of us up here pretty much. But what's really exciting about this is that we finally have gotten past targeted therapy bevacizumab, which does not have a biomarker. And we heard about that this morning as well. Can't really know who's benefiting from the Bev, but we finally have mirvetuximab, which is an antibody drug conjugate. And so this is the trial that led to the FDA accelerated approval. SORAYA, 106 patients were put on. It was a single arm pivotal trial. The key eligibility, I just want to point out, everybody had to have prior bevacizumab, and that was so that they could get past the Aurelia label with the FDA. 1 to 3 priors, and they did allow patients with BRCA mutations, and they defined it as a folate receptor alpha positive greater than or equal to 75%, that PS2 score. And the primary endpoint was response rate, which it was 32.4%. It met its primary objective, and the FDA did give accelerated approval based on that. And then Mirasol was Dr. Moore's trial. So this was the confirmatory phase 3. It took mirvetuximab against investigator choice chemo. I just have a couple of points to make out. First of all, you'll see that the response rate is a little bit higher in this, 42% compared to SORAYA, which was 32%. And perhaps part of that is because of everybody on that other trial needed to have bevacizumab, whereas everybody on this trial did not have prior bevacizumab. The response rate for investigator choice chemo is not that great, 16%. Right, so that's why we need to keep doing trials and finding better agents. On the left is the progression-free survival. You'll see the hazard ratio is 0.65. On the right is the OS, and so this was the first time we showed targeted therapy benefit at overall survival and platinum resistance. Hazard ratio is 0.67. I think we can feel really confident about these results. When you have hazard ratio, it's almost the same when you're talking about PFS and OS. And the other thing I want to point out is you see that orange thing on the PFS. A lot of patients fell off on the investigator choice, about 30% at first CT, six to 8 weeks. And then these are the others. So I think some of my stuff got a little bit misaligned, but anyway, the pink is all these platinums. So you see platinum now on platinum resistant. That didn't used to be the way, but this is where we're getting to the idea of platinum-free interval and that it's a continuum, right? There's nothing different between 5 months and 3 weeks versus 6 months and 1 day. It's just what day we got their CAT scan or when they were scheduled for their appointment, et cetera. And so there is some data showing that platinum is still an effective agent, even when they're quote unquote platinum resistant. That's just a cutoff. And the other thing I wanted to point out is that there is trastuzumab deruxtecan as well. And this is IHC 3+ or 2+. To be clear, the FDA label said 3+, but based on this compendia, you should be able to get it for your 2+ patients as well. And these are just the platinum combos in PROC. So some of these are prospective studies, some of these were retrospective studies, but showing decent response rates, right? Like this is still beating what we've seen with some of the non-platinum agents. So just remember that just because they're quote unquote platinum resistant does not mean that platinum may not still benefit the patient. And then this was the Forward 2 study that Dr. Moore spoke about as a phase 1/2 with MIRV and BEV. And so it included patients both that would be considered platinum sensitive and platinum resistant, so PF5 greater than or equal to 6 months. And you can see that they did enroll patients who had high, medium, and low expression. And you can see about 60% had prior bevacizumab and about a quarter had prior PARPs. And these were the results. The overall response rate was 44%. Obviously, the highest was in the high folate receptor, but there are still responses in those low and medium. And then the other thing I wanted to point out was just kind of in the middle. You can see that platinum-free interval less than 6 months and greater than 6 months. It's not that different, actually. So the response rate was 44% in the less than 6 month population and 48% in the greater than 6 month. And so just throwing this up there were really no surprises in the safety. It's what you would expect when you give bevacizumab. It didn't, there was no additive toxicity. We didn't see more of the types of tox that you might see with MIRV by adding bevacizumab to it. So it's all the things that you would expect: high blood pressure, protein, you're always at risk for bowel perforation if you give bev, high blood pressure. And then I think everybody is probably familiar with the DESTINY pan-tumor. But this was the study that showed ovarian cancers highlighted in red. It had lots of different basket. The patients were supposed to have 2+ or 3+, and it could be assessed locally. And then it was sent for central testing. And so you'll see some patients with 1+, even HER2 made it on this. And another thing to point out is that this was gastric cancer scoring. So if you have it done locally, you want to know how your pathologist is assessing, because in the past, we still don't actually have a validated way of assessing HER2 in gyn cancers. But in the past, mostly they were using breast cancer scoring. Gastric may be a better way to look at it for both ovary and uterine. And so that's what this used to use gastric scoring. But there was not a complete concordance between local and central testing. And these were the results. I mean, I think that's pretty impressive. Of course, we have to take this small trial, right? 40 patients, but that's pretty impressive when you're taking patients like this, 45% response rate, 64% of IHC3, but still very high even for the IHC2. So I think the FDA's decision to restrict it to 3+ is a little bit interesting based on the data that we saw. And on the left is the PFS, and on the right is the OS. And so they're not that different, but you can definitely see a longer duration of response in those 3+. It's much shorter in the 2+ or less. And then just a couple of things of toxicity that was concerned about was ILD, which is interstitial lung disease, or pneumonitis. So I do just want to bring this up. This is different than other drugs. So if you have a grade 1 pneumonitis on TDXD, you need to interrupt the drug. And your radiologist is not going to tell you it's pneumonitis. You have to figure that out for yourself. So the report is likely going to see, we see some ground glass opacities, or we see some signs of inflammation or infection clinically correlate. If you get a report like that, you should interrupt the drug. You should send your patient to a pulmonologist for a consult, and in general, also get PFTs. And the other things you want to be asking about are, do they have cough or shortness of breath? You want to assess their O2 sats. But the key is to find this early before it becomes symptomatic. And a lot of people will start steroids for a grade 1 pneumonitis with TDXD. So I just want you to remember that. And the D is the deruxtecan. So there are other drugs coming that have the same payload. And so it is, there can be a class effect of pneumonitis from ADCs, and we definitely see it with this deruxtecan. And if you can interrupt it, it'll resolve a lot of times, especially with some steroids, and then hopefully you can resume the drug. And the other thing is just because it was a HER2 targeting agent, there was AESI also of left ventricular dysfunction, and they did not see very much of that. So we can be reassured about that. So just to summarize, basically, when I was a fellow or just starting out, there were none of these. None of this existed. And now we have all these biomarkers. In fact, when I first started in practice, I'm like, there were these NGS or whatever, and I'd send them, and then I'd get these things back. I'm like, I can't act on any of this stuff. This is a waste of my time. So for a while, I stopped checking these tests because I couldn't do anything with the information. And now, there's not a patient I see that doesn't have something that I'm like, okay, I have a trial for you, or this drug might not work for you. And so it's really nice to have gotten to the level of personalized medicine in gyn cancers. And so in conclusion, again, I just can't, state enough. We know that we're not doing this on everybody. So we really need to germline test everybody with epithelial ovarian cancer. We should be doing tumor testing in advanced non-BRCA mutated ovarian cancer, and then all recurrent and persistent ovarian cancer. Personalized medicine is here, and to becoming our more biomarkers. Thank you.
I would like to point out that 2 of the dogs, well, actually the 2 dogs are both from me. I'm not responsible for Sebastian the cat, although I did give him that laptop as a gift. It's true.
It's true.
It's true. All right.
If you work in Oklahoma, you'll have a Katie Moore dog. And there are also other people that have Katie Moore dogs that do not work in Oklahoma. So
Yeah.
if you need a dog, just talk to Katie Moore.
Yeah. Yes. Talk to me. So let's go on to case presentation 2. So a little bit different. This is a 66-year-old diagnosed with stage 3C high-grade serous ovarian cancer now in 2019. She had a primary side reduction to no gross residual. Probably Debbie did it. Followed by paclitaxel and carboplatin and Bev. And then she got Bev maintenance for a year. She actually had testing sent from her first surgery, and she is known to be BRCA wild type and HRD test negative, which is why the bevacizumab was continued. She recurred 18 months after her last platinum. So she got Bev for a year and stopped, didn't progress. And about 6 months after that, 18 months from her last platinum, progresses with abdominal disease. And so it was reinitiated with carbo PLD again and bevacizumab. That's kind of our favorite platinum sensitive regimen in Oklahoma. She got 6 cycles. She actually responded, not a complete response, but a partial response. And so continued the bevacizumab as maintenance. And about 5 months later, has a recurrence after that second platinum. And so she gets imaging brought in for imaging to work up what was a rising CA-125, and has new liver metastases. And they were small, but they were there and real. No bowel obstruction. Does have some moderate ascites on the CT scan, not yet super symptomatic, but a fair amount. Performance status is good. So any next gen sequencing, anything else you guys would be ordering for her at this point?
Just make sure your next gen sequencing includes whatever necessary IHC markers might not be included by some companies.
Yeah, it is different. They're different tests. So these are hers. So we did that. Her first sequencing was just the assay that does HRD and BRCA. So we sent full panel, and you can see it here. So she's folate receptor alpha high. 200% of her cells are 2+. This is a real report. ERBB2, HER2 0, IHC. She's microsatellite stable, as one would expect. BRCA wild type we already knew. And you can kind of see the rest of the markers there. Here are the kind of from a clinical trial. Again, these are supposed to be a different color. We do look for folate again because we have a lot of trials with novel folate agents. We're looking for a certain TP53, Y220C. She doesn't have it. ARID1A, she doesn't have a mutation. Cyclin E, she doesn't have an amplification, but these are all the things we're kind of checking off our boxes as we're looking at things. And we also look at our site for HLA status to look for potential links to engineered T cells and bispecifics that are HLA linked, so that in our institution and those of you that have these open, it's sort of part of the biomarker write-up, whether or not someone is HLA 0201 or 0202 to correlate with some of these studies. And we'll talk a smidgen about that later. And you can see her IHC at the bottom there. So here's her kind of characterization: BRCA wild type, HRD negative, folate receptor alpha high, and she's HLA 0201. So from a standard of care standpoint, she has mirvetuximab monotherapy. From an NCCN standpoint, she has MIRV-BEV, and we've just talked about that. And then she has many trials. Every folate drug, she'd be eligible for, and then she would be a potential for some of the bispecifics and engineered T cells as well. So she has a lot of options. So what happened to her? So we started mirvetuximab and bevacizumab, and we can talk about, this is my patient, so I can tell you why, but I'll ask my panel first. And we sent tissue testing for the proteins MAGE4 and PRAME for some of our HLA linked, kind of to line up options. That's what we do, right? You kind of line up your next lineup of options. So we had that pending, but started MIRV and BEV first. And so just to kind of go back through, we've already gone through the NCCN guidelines. You can see mirvetuximab here as a monotherapy is a category 1 because it has an FDA approval. She does certainly have the Aurelia option. I should have put that as standard of care. That was biased of me. So that's certainly an option for her as well. Chemotherapy plus bevacizumab. Is it still an option here? I'll ask my panel. She had bevacizumab. Do you think that this is still an option for her? Yeah, we kind of talked about that. Bev after Bev, we use that. Europe, they don't. It's a different conversation there. And then here's the Mirasol data that I just showed it in a different slide, just in case you missed Debbie's, but same data showing PFS, OS, and overall response rate benefit. And we have MIRV-BEV. And so this was sort of the question, and the reason I put her on both, because this is my patient, is because of the ascites. And I just did that, no data, but I just did that based on the ascites. Is that, what would you have done? 100% folate expression. Like, we don't see that very often. Would you have just gone with monotherapy and then added the BEV if you needed it? Would you have done the same thing? Kind of what would your selection have been, Dr. Reimel?
I would have done monotherapy and added the BEV if the ascites didn't clear or I felt like I needed an extra oomph. I get really nervous about bowel perforation because I really hate that. So
That's fair.
I just really hate that.
It's fair. How about Dr. Fu?
Yeah, I would do the same. I would do monotherapy with MIRV first and to see, how she's symptomatically feeling through ascites. If after 1 or 2 cycles, really no difference or worsening, then I would add the BEV.
Yeah. Debbie?
I would do the same thing as my colleagues here.
Yeah. So that's good. You have differences. I'm right. I'm just kidding. But there's an art, right? So you sort of pick things based on the patient in front of you. And I think that's important for younger physicians and fellows to understand. There's no right answer here. It's just sort of, you have to use the data and do the best for your patient in front of you. So for her, this patient, I started her on MIRV-BEV. She was responding, actually did great on it, but came in for cycle 3, day 1, with a CT scan showing response, really happy, except she had new blurry vision. And still drove herself in because that's what they always do. But it was like, I have blurry vision, but I drove myself here, right? These are all the time.
Always.
You're like, okay, Uber. So we held her, clearly held her, and sent her for ophthalmologic workup. And we're eventually able to restart. And she actually continued through cycle 10 when she eventually had progression. And she's now progressing or proceeding potentially with engineered T cells. But let's go back to cycle 3, day 1, when she comes into the office, because you'll see this about 50% of the time with mirvetuximab. Patients will come in with some sort of ocular disturbance, and it's right about this time. And so what do you do and how do they present? And I'm going to ask Dr. Reimel take her from cycle 3, day 1. And I'll come back to Surpass in a second. Here we go.
Okay. Hi. So I'm going to talk a little bit about the eyeball, which is, a safe space for gynecologists. Okay. So, as Dr. Moore mentioned, this patient presents around cycle 3. She has her ophthalmology exam, which we'll talk about why that's standard of care. Her vision originally was 20/20. Now the ophthalmologist report says 20/60. That's worse, just so you know. Microcysts are described as present, and the patient's complaining of some mild blurriness. My patients frequently say, it's hard to read my phone without my reading glasses. That's like a common presenting complaint, and she has some mild dry eyes. So if you're like me and you chose your specialty based on its distance from the eyeball, which is just gross and squishy and produces things I don't want to think about, this is a little lesson in eye anatomy because it sort of matters how we got here and what this looks like. And it turns out that the eye speculum, which is the retractor used to open the eye during surgery, is so repulsive to me that I brought you a cartoon of it. But if you wanted to know where spectacles speculum come from, it's from the eye. Okay, so ADCs have ocular toxicity. Mirvetuximab specifically has, as Dr. Moore mentioned, about 50% of patients presented with an ocular toxicity, mostly blurred vision, some keratopathy, some dry eye. The parts of the eye are important because they turn over, all these different epithelial layers turn over at different rates and have different susceptibilities to some of these compounds that we're using. In this particular case, the cornea has several layers, and the surface epithelium replaces itself more quickly than the other layers, like the stroma and the endothelium. So why is this happening to us? Why are we talking about the eye? And it turns out that there's this portion of the eye where the corneal cells are regenerated from. This is the limbic region, limbo in between, limbus, and it contains the stem cells that repopulate the cornea, and they're particularly sensitive. If they're slow to recover, the shape of the cornea will change, and the light as it's coming through will be refracted differently, and you get blurry vision. Okay. The reason that these limbic cells are so sensitive is because of some things that seem to happen specific to limbic cells. They are very susceptible to pinocytosis, either receptor mediated or non-receptor mediated. And pinocytosis is that cool thing where something sticks onto the cell surface, the cell membrane starts to pick it up, it pulls it in and becomes these little cystic structures, lysosomal structures. And that can happen either because there's a binding site or because it's sticky and it sticks there and it goes through. And that's what microcysts look like. So this is a picture of the eye stained with fluorescein during a slit lamp examination. And you can see these tiny little microcysts, which make it really hard to see through and thus blurry vision. Are you all impressed? Me too. Okay, but it's really important that we recognize what happens to the eye and we have to ask questions about it. About 50% of patients are going to have either keratopathy or blurred vision or both. And so we really have to ask about vision and whether or not they're completing their tasks of daily living. So driving, we already mentioned, really important, but also really important if you're having trouble seeing your computer screen, if you're having trouble reading the label of the bottles of your medication, this can really end up being a sort of cascading problem throughout the patient's life. So can it be reversed? Thankfully, yes. It's really limited to the corneal epithelium. Deeper corneal layers are not affected, we think, because they turn over at a different rate, and also because they don't seem to take up the antibody drug conjugate in the same way. And then eventually, as the cornea sheds and new cells become available, we get rid of it. So that's why dose delay works really well. And then for everybody who had complete follow-up data, all the ocular AEs resolved to grade 0 or 1. So it's very reassuring. We're not going to have permanent problems like some of the other ADCs like tisotumab vedotin, where you can actually have longer-term problems even after drug cessation. So just to keep in mind, mirvetuximab didn't result in any corneal ulcers or perforations in the available studies. So we screen everybody for this. You have to screen everybody. You should go, all the patients should have a baseline ophthalmologic exam, which includes that slit lamp examination. So you can look for those microcysts prior to the beginning of mirvetuximab, and then every other cycle for the first 8 cycles as clinically indicated. Not very many people make it past 8 cycles, so it's usually pretty easy. We can also prevent this wonderfully by using corticosteroid eye drops. We use 1% prednisolone on the day before treatment, -1, all the way through day 4. Do that 6 times a day, and then days 5 to 8, you could do it 1 time a day. And you have to wait 10 minutes between the drop types. So we also use lubricating drops recommended to be done 4 times a day, but we don't put the steroid drops in and then the lubricating drops because then you've washed away the steroid. So it's at least 10 minutes in between. Okay. Pro tip, no contacts. So make sure that your patients have an up-to-date spectacle prescription, glasses prescription, before they start the mirvetuximab. Otherwise, they really can't read or drive or do anything because they don't have any glasses. Okay, another ocular toxicity. Okay, so this is what we really should make sure that we know about the grading of ocular toxicity and how to treat it. So for grade 1, the protocol guidance for management for this is basically you get your eye exam. If there's no change in this schedule, you could just monitor for worsening symptoms. For grade 2, though, we wanted to hold the mirvetuximab until grade 1 or better. And then for grade 3, you withhold the dose until approved or resolved, and then reduce by 1 dose level. And that's for those people who are symptomatic, especially with ADLs, or have significant visual acuity changes. And then for anybody that gets all the way to visual acuity of 2/200, that's like really, really bad. You want to make sure that those people are permanently discontinued, although that's pretty rare. It should be mentioned that there are other potential side effects and toxicity of mirvetuximab. Things that seem to be a little bit more specific to this drug are a little bit more diarrhea than we usually see, and a little bit of peripheral neuropathy, similar to what we see with the taxanes. But everything else is pretty good. And that's it.
Yeah, thank you. So we're doing just fine on time. So let's just have a little discussion because I think the toxicity management is important, especially for new users for mirvetuximab. I think Dr. Richardson and I are fortunate in that we've had all the studies open. So we've been using this medication for almost a decade, actually over a decade. So to us, it's like, it's, super easy. But to someone that's never used this, it's really daunting. I'm sorry I have my back to y'all. I'm going to talk this way for a bit. It's really daunting. Patients get very nervous about any discussion of ocular toxicity, and the kind of barrier to communicate with an ophthalmologist or an optometrist can seem like a barrier as well. So I just want to turn it over to the panel. How do you counsel a patient about the ocular toxicity when you're sitting down with her? For someone that this 100% 2+, they're like, I'm using Mirv one way or the other. What's your counseling look like? And specifically, and maybe not just specifically, Drs. Reimel and Fu can correct me, but in our part of the world, we take care of a lot of patients who have significant financial toxicity potential, and going to an ophthalmologist can be pricey. So can we just speak to the realities of utilizing mirvetuximab? Like, what do you do?
Sure. So we made a lot of friends in our optho group. We have like a medical group that works with our hospital that's not faculty. They're just non-faculty excellent clinicians. And so we now have like partners in crime over there that we call when we have new patients. So those patients are mostly covered under the insurance plans that our hospitals see. But it took reaching out and talking to them. I have this new drug. I'm going to send you a lot of patients. I need them to be able to get in to see you quickly. They can't wait 12 weeks. They need to come in tomorrow. And so we made friends. That was one of the things that we really helped, that helped us. Where we live, Costco also has optho at Costco. And so they could go to Costco for eye exams. I know in some places they can use Walmart as another potential place. We don't really have a lot of Walmart in LA. Those are the big things. And then the other thing was that for us, steroid eye drops were not covered under some insurance plans. And so we had to work with our pharmacy to order particular brands that would be covered for many of our insurers. So it took a lot of like coordinating and talking to people. And I felt like this is one of the drugs that I learned, like when Pembro came along, I made a lot of dermatology friends, and now I have a lot of eye friends because these new toxicities give me more opportunities to reach out to people that I'm working with.
Yes.
Yeah, I agree. And I think echoing just making those relationships, but also having things in writing so that the patients can actually really kind of visualize also in terms of eye drops, it does get very confusing. So I think practically having your nurses and staff check in too with them to really follow along was pretty critical.
And just to add to what we do at our place, we luckily have PharmD embedded into our team. So she does a lot of our counseling and handouts. But I also will tell you that the company has made handouts for patients and also for eye care providers. And you can go to a website and there's the website for the patients and there's a website like link for the healthcare professional and it tells them exactly what they need to be looking for. And so I think that's important as well to utilize those resources. And then we actually stock the eye drops that are needed both for this and for tisotumab. Not that we're talking about that so much today at our cancer center so that our patients can have their eye drops pretty easy to try and avoid some of the issues with them not being able to fill, et cetera.
And we use a lot of Walmart. We have Walmart in Oklahoma. And because Target's real is bougie.
We have Target too, okay?
We
Let's
do have
not make people think we live in the middle of nowhere.
No, we do have Target, but our patients like, I don't go there. They go to Walmart and they have optometrists and optometrists are fully qualified to do the exams on mirvetuximab that are needed. And it's like a $7 copay or so it's still a little bit of cash output, but for our patients that have a lot of financial limitations and also have to like work jobs to keep their insurance and they can't keep like normal office hours, they can go to Walmart on a Saturday often and get these eye exams. And so you can be creative and maintain the safety that the treatment requires and not have patients really put out of jobs and other things that are quite important, as we use these more labor intensive drugs. And so just to come back, in my patient, she had very mild symptoms, but did have visual acuity changes. And so was a grade 2, and it resolved really fast, like 100% resolution. But it took a little longer than a week. And so we did dose modify her. But do you always have to dose modify for grade 2? Can you ever restart? Like, what's your recommendation for the group in terms of when can you restart at full dose? When do you have to dose modify for these, not grade 3, of course, but grade
Right. So for
2s?
this squishier grade 2s, I think if they resolve completely to baseline, you can definitely restart if they go to 0. If they're still using those reading glass, that's like if they're still using reading glasses, then I usually will dose reduce, or if they're still having symptomatic dry eye. So if they maintain some symptomatology, then I will dose reduce.
Yeah. Any other
Yeah,
comments?
I agree with that.
Yeah. The photophobia that they can get, if they just have like they're like, oh, the light bugs me, that you don't have to hold and modify for. You can just watch it. And that's the slide that we showed, you'll get a copy of, and it's just a really helpful slide to put in your office for your APPs and yourself just to kind of recognize, because we just don't grade ocular disturbances every day. It's not second nature. Kind of like pneumonitis, which we'll get to. So we're just trying to provide some tools to use. So good. Okay. So I think that rounds out that case. As I said, she did recover, went back on medication and was on for about 10 cycles. So she went beyond the 8. So sometimes you can see these patients do well for a long period of time and is currently in screening for engineered T cell targeting MAGE-A4 on the Adaptimmune trial. So we're pretty excited about that opportunity for her as well. Keeping her off Doxil as long as possible. All right, this is the last case. So this is, and we'll have a discussion. This is a 72-year-old diagnosed with 3C high-grade serous ovarian cancer in 2019. Again, she was treated with neoadjuvant chemotherapy and bevacizumab, had an interval surgery, and then got bevacizumab maintenance for a year. She had her tumor sent for testing at the time of interval and was BRCA wild type, but was found to be HRD test positive. And so this was, I don't know why she was on Bev, but she was. So she recurred 24 months, so 2 years after her last carboplatin with liver mets. Got carbodoxil for 6 cycles with a partial response, and then was put on PARP at that point for a year, and then had progression. And then went back on carboplatin again, so has gotten her 3rd carboplatin, 4 cycles in, and had progression. So she gets imaging. She also has liver metastases, no ascites this time, no obstruction, really just the liver is her main site of disease. This is a patient that actually Debbie and I share. I can't remember why she didn't get PARP in the front line, but we can talk about later. Can't remember. Someone else did it. Just kidding. There was probably a reason. And so she's interesting. So she is HRD positive. She was very sensitive to platinum, has now gotten 3 platinums, which we're seeing more of, these patients that are getting platinum after platinum after platinum. And we tend to use platinum until platinum doesn't work anymore. She did get her updated testing sent, and these are her results. So we knew she was HRD positive on this assay, again, was positive. So concordant, microsatellite stable. We knew she was BRCA wild type. She is HER2 non-amplified, and HLA didn't match. But here you can see at the bottom for her immunohistochemistry, she's HER2 2+, and she's folate 2 plus 40%. So she's a folate medium and HER2 2+. So neither of these match to FDA, but both of them have an NCCN listing, and you have 2 ADCs. So we're already here. We're already here in this position of having to pick which ADC we want to use, without really the comparative data to know which one is best. So this is sort of, we thought this was in the future, but it's already here. And it's actually just going to get more complex as more ADCs come into play. She also, from a clinical trial standpoint, had a TP53Y220C mutation, which is about 4% of ovarian cancer and is now targetable. And so we do want to make sure that you all know that. So go back through and look at your TP53, because this trial is ongoing. This medication works. So we want to find all of our patients. With this, we're not talking about it too much today, but I know Dr. Richardson will want to mention it. She's running the study at our site. She doesn't have an ARID1A or cyclin E amplification, but we always look at those. And then her HLA, she was 0201. Yeah, I forgot about that. So here's her kind of biomarker spread: BRCA wild type, HRD positive historically. She's probably not anymore, as she's progressed on a platinum. Folate receptor alpha medium, HER2 2+. And we did do ISH, and it was ISH negative. She's got a TP53Y220C, and she's HLA 0201 coming into 4th line. So tons of options on a clinical trial standpoint and in CCN. Standard of care wise, we don't have a match. Of course, chemo is there. Aurelia is there if we want to use it. That's true. But from a biomarker standpoint, I don't have any FDA approved matches. In CCN, I have a match with trastuzumab deruxtecan because of the 2+, and MIRV-BEV because of the folate expression. And then I have lots of trials, too many trials to mention. And so what do we think about here to the panel? Now we're 3 prior lines, prior BEV and prior PARP. She progressed on all of those things, now including a platinum. So this tumor has shown it's grown through BEV, PARP, platinum. What are you thinking about kind of here in a PARP resistant, platinum resistant setting? Kind of how do you think about this space? We'll talk about it a little bit more at the end of this symposium, but just briefly, what do you think about when we see these patients now? How are they the same as platinum resistant? Are you thinking about them differently? Like, how are you thinking about options in this new kind of phenotype? Or is it different? Or do you know?
Seems like data is still emerging about how to deal with this. I think you're going to tell us, or somebody has this great slide coming up soon about regression on PARP and what happens to platinum response after progression on PARP. But not to give away the slide, but it seems that there's a reduction in response to platinum after progression on PARP. And so that's something to consider with these kinds of patients, that maybe we want to think bigger about what the next line of therapy would be.
Yeah.
But I also look at somebody who's had that many lines of platinum as somebody who is a responder phenotype. And so they hopefully are going to do well on maybe a non-platinum agent. And of course, I'm going to look for a clinical trial, but if not, I'm going to go over both like standard of care chemo options and maybe some of the NCCN options that may not be FDA labeled.
Yeah.
Yeah, I would say for her, she progressed on platinum. She had the PARP. So yeah, definitely trying to maybe think about a different category for treatment.
Yeah, I think it's emerging. I think you're right, Dr. Ryan. We don't know yet. We're all kind of guessing, but we need to figure it out relatively soon because the patient's already here and they need us to know this and we don't know it yet. So just to kind of tell you what is known, what is known so far is exploratory. And so we have to be very cautious. And I think you heard some caution in sort of making definitive statements because we don't really know yet. We haven't studied this in a prospective way, but we have seen exploratory data from a few studies. This is the first data to come out was we call it the Fresnel analysis. If you're wondering who that is, he's like a super smart, nice guy who looked at Solo 2, which was platinum sensitive recurrent disease, PARP naive, and they received olaparib or placebo. And it was a phenomenal success and led to Solo 1 and other things. But he said, well, you know, what happened amongst the patients who were platinum sensitive again and got platinum who were on PARP or on placebo? How did they do? And what he found here, and you can see that on the left-hand side of the slide, is that the patients who received olaparib and then were still platinum sensitive and got a platinum again versus the patients who received placebo were platinum sensitive and got platinum again. So you can already see there's a difference in the population. The patients who got olaparib actually did worse from a progression-free survival standpoint, 7 versus 14 months, so about half as long a PFS. Now you ask yourself the obvious questions. Did the patients on the placebo group get platinum plus a PARP at that point? And is that what explained it? There's lots of biases in this analysis that could make this a wrong conclusion, but it was the first sort of antenna raising prospective analysis that came out that made us say, huh, you know, are we doing something to tumors that progress on a PARP in the recurrent setting that makes them worse in subsequent lines of platinum? And we have not answered this question yet. A similar though and provocative study, exploratory analysis came out of Paolo 1, and this hasn't been published yet. So if you weren't at a European meeting, you may not have seen this analysis. So I'm going to just show it to you briefly here. This is Paolo 1 frontline now. So Solo 2 was a platinum sensitive where you use PARP or whatever indefinitely. Here we're using a PARP for 2 years. And it says, okay, of the patients who progressed after receiving PARP, BEV, or BEV, and were platinum sensitive, which was most patients, and got another platinum, how'd they do? Based on progression during the PARP and still being platinum sensitive, or progression after the PARP and still being platinum sensitive. And this is what they found. The red line is the PFS curve for the patients who were randomized to olaparib and progressed during the olaparib. The yellow line is the patients who were randomized to olaparib and progressed after they completed their olaparib. And then the blue line is the control. So the first thing you say is, well, no duh. If you progress during the PARP, that means you progressed during the first 2 years. And if you progressed after the PARP, that means you progressed longer. And so we already knew that. That's prognostic. That's the platinum-free interval. And that's probably true. These are probably biologically different tumors. But there is something still interesting to this exploratory analysis. And I think the most concerning thing to me is that the median progression-free survival for the group that progressed during their PARP, so during the first 2 years post-platinum, is 7 months. Well, that's platinum resistance. You start a platinum and you have progressed by 7 months. That means half the patients at the very least are platinum resistant. And I find it hard to believe that very many made it 6 months or beyond that next line of platinum. Some probably did. So that's already a largely platinum resistant population coming right out of the gates. Is this true? We don't know because it's an exploratory analysis. And exploratory analyses, you just have to say, this is hypothesis generating. I'm not going to make clinical decisions. I'm not going to stop giving platinum in this space. Please don't do that. But I would ask you if there's a study that's coming that maybe asks that question, should we use something else? Be open to it. Because there may be something we can do that's better than platinum in a group of tumors that progress quickly on a PARP. But this is really where there's a lot of equipoise right now and understanding what's happening. So when we look at the NCCN guidelines, again, for this patient, she doesn't have folate receptor alpha high, so this one doesn't apply. She does have HER2 2+. She does have folate medium. So both of these apply, plus every other option on the NCCN. And so she has a lot of things to consider. You've already heard, and Dr. Richardson showed you the Destiny Pan tumor. I'm just pulling just specifically the ovarian down to highlight. It's 40 patients. So we just have to take that a little bit with a grain of salt. It's a phenomenal study. But it's 40 patients, and we have a ton to learn about how we use biomarkers to select this drug versus another drug. But for essentially 3+, confirmed 3+, which is only 11 of the 40, the response rate is 64%. That's coming close to like frontline platinum. That's pretty good if that's true. We'll see with more patients. This study is reopened to get more patients on, so I think we're going to get some better estimates. But even the 2+ is pretty good, but 36% versus 42% on mirvetuximab, but that's high. I don't have the data for 2+. Then it starts to get wishy-washy about what you pick. So you have to guess. And I don't like that. I guess I'm talking about this one. So the TP53, we wanted to make you guys aware of this because it's such a rare mutation that we wanted you to all know that this was now targetable. So look for these on your whatever reports, Y220C, go home and search for them. If you have any of them and they need a clinical trial, I would email one of us and we can tell you where it's open. It's open nationwide. It's a basket study. You can see the ovarian carved out in purple. This is data that predates what Allison Schramm presented at SGO. Many of you may have seen this at SGO. It looks better than this now with more patients. So this is a very active medication. How we use it and how we develop it in such a rare subtype remains to be seen. But if I had a recurrent tumor, I would want to get them access to this. So we wanted to make sure you were aware of it. Folate receptor alpha also has, once you develop a good drug, everybody comes after you with next generation options, which is good. Where would we be in lung? I mean, I know we're not lung doctors, but if you're at ASCO, what a year for lung cancer. Like they had survival curves with like a truck in the middle, kind of like Solo One. I mean, it's so exciting to see this for lung cancer. And it's because there's next, second, and third, and fourth generation EGFR and KRAS. Like, if you don't develop better drugs, you don't really move the needle. And so that's just drug development. This is what's coming after MIRV. And some of them may not make it, and some of them may be better, and some of them we may use both. But these are all in clinical trials. And I think it's an exciting time to really fully understand how we kind of exploit this tumor-associated antigen to best serve our patients. So just to round out with this, what happened with this patient, and I'm going to turn it over to Dr. Fu. So she, we had to guess, like I said, and so I had a HER2 ADC open. I think I counseled her for this. Debbie and I share this patient. So she went on a drug very similar to trastuzumab deruxtecan. It's just a different sponsor, but a topo-1 payload. She had a beautiful response, near complete response for a year. But had to come off because of grade 1 pneumonitis. Completely asymptomatic, just didn't resolve within the 48 days we had for it to resolve. And so she had to discontinue, and then we didn't even restart her for a long time because the drug just works. And so eventually her liver mets grew back, and she went on the Y220C drug that Debbie runs at our site, and then eventually also went on a novel folate targeting ADC, which was her last regimen. So she had a lot of options, but wouldn't have been nice to know which. I think I picked right, but who knows? Kind of sometimes you guess right and sometimes you guess wrong. So we need more data to really sequence these drugs up front. So I think key takeaways are here. The impact of PARP on mechanisms of resistance. You're seeing, if you were at ASCO and you saw Fiona, Dr. Simpkins present the Capri study, you got a sense of the amount of really impressive and things I have to read honestly 3 times. Whenever Fiona publishes something, I'm like, so much depth to understanding the mechanisms of PARP resistance. We are getting there. Stephanie LaRue, Fiona Simpkins, like Catherine Fu, publishing things that are helping us develop drugs and combinations that are going to come at these tumors in a way that we're not guessing. So I think our future is incredibly bright. So stay tuned there. These other things are just the same things. You have to have tumor tumor, tumor, tumor. So we can keep testing as these new biomarkers come out. Sequencing is already here. And so we really need to understand the biomarkers so we can sequence without guessing, and then early referral for trials or talking to your friends that have trials open so we can make sure that availability is more broad to patients that are treated at excellent places that don't have all the trials open. So with that, I'm going to turn it over to the question of sequencing, which I've already said is hard. So of course I've asked Dr. Fu to talk about something that is hard. So Dr. Fu, take it away.
Thank you. So thank you for this opportunity to really address this very straightforward topic on strategic sequencing oncology, integrating our ADCs and other target therapies. So really before, you're going to see a lot of the same slides, but really in this portion of the talk is really to think about, how do we sequence? Like, let's take into account the specifics of the trials, how many prior lines have they had, and also when we think of our patients, what are the residual side effects that they have that we can maybe help with the sequencing, and then what are the side effects of the actual ADCs themselves, and how can we actually also use that within the context of the residual side effects. So just thinking about that in this next, I guess, 15 minutes or so. But before we even start with sequencing, let's talk about what are the FDA-approved ADCs in GYN cancers. We've really been talking about ovarian cancer, but just to kind of broad, picture, this is what's FDA approved, and then I'll show in the next slide the NCCN, which we've seen already, but just really trying to see the differences when you look at the slides, back to back. So FDA-approved ADCs in GYN cancers, cervical cancer, we know about tisotumab, recurrent metastatic disease. Ovarian cancer, platinum-resistant ovarian cancer, we know about folate receptor, 75% or greater for mirvetuximab. And then for cervical, ovarian, and endometrial, trastuzumab deruxtecan for HER2 IHC3+. So this is FDA approved. Now, in terms of NCCN guidelines, you'll see, and we've talked about this a lot already, in terms of cervical cancer, similar. Ovarian cancer, platinum sensitive, we can add in the bevacizumab, which we've already talked about. And this is, again, is folate receptor alpha expressing, so not limited to high, and also including the median based on the 402 study. Platinum resistant, we're also including, again, the bevacizumab for folate receptor expressing tumors. And then again, for the trastuzumab deruxtecan, IHC2+ and 3+. So some of you may be asking, what is the platinum sensitive data for mirvetuximab with bevacizumab? And this was actually presented by Dr. O'Malley in 2001 at ASCO. And so I'll just kind of quickly show you some of that data. And when we look at this study, you can see down below in the platinum-free interval, this is, kind of very similar to what Dr. Richardson published or talked about, but also looking at exactly how about 50% were had platinum-free interval of 6 months or greater. You can see below there. And then when you look at the total population for those patients who had the folate receptor expression and response of 50%, and when you actually look at the high folate receptor expression, you can see 64%. When you break it down between platinum resistant and platinum sensitive, you can see up to 69% response with mirvetuximab and bevacizumab and platinum sensitive. So what about the duration of response? That's always really important when we think about this treatment, and also when your patients are asking you, well, how long can I expect to be on this regimen? So you can see in the platinum sensitive setting there with a high folate receptor expression, it's about 12.7 months. And so you may be asking yourself, well, what's the duration? Is it a deep response? You can see by these waterfall curves and the spider plots that they're, it's pretty significant with these durable responses. And so when we look at the PFS, you can see also about 13 months for the high folate receptor expressing tumors and platinum sensitive ovarian cancer in the combination again of MIRV plus Bev. So how does this relate to what we already know? We know that there's chemotherapy backbones that we can give in platinum sensitive regimens. You can see about 13 months that we just talked about MIRV plus Bev. And you can see compared to the other chemotherapies that we have, it's very similar, right? And actually even better with some of them. What about when we pair with anti-androgenic agents? You can see, compared to GOG 213 with carbopaclitaxel and bevacizumab, about 13.8 months. Again, very similar, PLD, carbo and bev, 13 months. So really very comparable. So just thinking about that as we're thinking about platinum sensitive. Piccolo trial, I don't know if many of you have seen this press release. This was actually just a week ago. This came out in terms of just the press release itself, so I have as much information as you probably have via Google. I haven't done AI to this yet, but in terms of single arm trial, mirvetuximab, 75 patients, platinum sensitive, and just really think about 2 prior platinum containing regimens. So, sometimes we think about platinum sensitive, we think about, okay, they just had 1 prior line. So this is actually 2 prior lines of platinum containing regimens. And you can see that here, the objective response rate is about 51.9% with single agent, folate receptor high, and then about 8 months for the duration of response. So more to come on this. This was just again released last week. So you've seen this, but just again, like really, we just took this from the May 2024 NCCN. See on your left there, preferred regimens for platinum resistant. As we're switching gears a little bit from platinum sensitive to platinum resistant, you can see again, single agent for 75% or higher folate receptor expression. Useful in certain circumstances, you can see with combination with bevacizumab and then trastuzumab deruxtecan 2+, 3+. Okay, so you've seen this before, but really just want to kind of highlight the specifics of the trial as we're thinking about sequencing and you're, trying to figure out, does this actually match what my patient has, based on the inclusion criteria. So high-grade serous cancers, 1 to 3 prior lines. So in this study, actually 50% of the patients had 3 prior lines of therapy. So thinking about it in that perspective, as you're trying to feel like you're heavily pretreated, would they actually benefit from this single agent bevacizumab? Seeing these curves, the improvement PFS, improvement in OS, but just really thinking about the specifics again of the trial itself. And then you also think about the side effects, adverse events. So you can see that actually the grade 3 and higher treatment emergent adverse events are actually lower in mirvetuximab compared to chemotherapy. And the discontinuation rate was actually lower in mirvetuximab compared to chemotherapy. So that really highlights that, when you're thinking about your patient and whether or not that this would be safe for them, you can kind of, look towards the data itself. And we've talked about the ocular adverse events, so we really won't go into that. But just really highlighting again, most are reversible. But the non-ocular events, so which ones are those? So nausea, diarrhea, fatigue, peripheral neuropathy. This, many of you know, mirvetuximab has an anti-tubulin payload, and so you can see that there is neuropathy, but it's lower than actually paclitaxel itself, mostly grade 1 and 2. And the one that we do want to point out, and we'll talk about in the next slides, are the pneumonitis. We've touched upon that a little bit already, but in terms of mirvetuximab, can be resumed in most cases of grade 1 to 2 pneumonitis, which is different than trastuzumab deruxtecan, which if it's grade 1, and we'll talk about that, is to interrupt, and then grade 2 you discontinue. So it's really these kind of important specifics and details when we think about our patients and sequencing. So here we talk about trastuzumab deruxtecan. You've seen this, but really again to highlight in terms of the prior. So there's 2 lines and more patient population. But if you look at the data itself, most patients had 1 line. There were just a few that had 2. More than 2 lines. And so you can see here, ovarian cancer, about 40% if you had 2 or more prior regimens. When you look at the PFS, so for those with IHC of 2+, is about 4 months. So if you want to cross-trial compare, you can kind of think about it and frame it in that sense too, in terms of thinking about sequencing and perhaps thinking about the objective response rate, but also the PFS as well. One question might be, well, what if the patients had prior HER2 therapy, prior topoisomerase therapy? Would that actually make them respond a little bit less? You can see ovarian cancer cohort, again, 40 patients, a very small number, but prior therapy actually did not actually decrease their response rate compared to no prior therapy. So safety summary, in terms of trastuzumab deruxtecan, the most common was nausea. We know how to treat nausea. There's real world evidence in terms of what you can give, and many of us know. But also looking at neutropenia, the highest for grade 3. So thinking about that in terms of dose reduction, starting with a lower dose for some of our heavily pretreated patients, that's another tip. And then the ILD pneumonitis was not a grade 3, but it's grade 1 and 2. But we'll talk about why, because it can easily progress to as a grade 1 and 2 to higher grades. And so we really need to be very careful about that. So what are some strategies? We're getting close to the end because I know it's been a long talk. So in terms of the 5 S's, so the first one is screening. So many of us will do a baseline and they say HR high resolution CT scan. I think most of our CT scans are high resolution, but really having that baseline, having your baseline O2 sat, talking to patients about their symptoms. Do they, not just about cough and shortness of breath, but also fever and any other symptoms they may have. So we talk about scanning already. Think about this getting the baseline and then actually repeating every 12 weeks, maybe 6 to 9 weeks actually, if they do have baseline respiratory symptoms present. And then synergy, really talking to them about the symptoms so they know and they're involved, having your pulmonologist involved as well too, as part of this care. In terms of suspending, so when do you think about suspending? So we talk a lot about grade 1, it's asymptomatic, which is why it's so hard, I guess, because you have these findings on the CT scan. We talked about those already. Infiltrates, ground glass opacities. You look at your patient, she looks great, she doesn't want to stop, but that's a sign to go ahead and interrupt treatment. And then you think about the 28 days. So if it's less than 28 days that they resolve, then you can continue. If it's greater than 28 days, and not if it's greater than 20 days and not resolved, then really think about reducing that dose. Considering steroids, you'll see the dosing for the steroids is different between grade 1 and grade 2. Grade 2 again is symptomatic, and so you can have that higher dose. Some on grade 1 don't start steroids, but certainly do consider starting steroids with the grade 1 ILD pneumonitis. So here's the last few slides to really kind of get to the meat of the matter. Like, how do you sequence? Is there any data for sequencing? This was actually presented by Dr. Erica Hamilton at ASCO this year, just a few weeks ago, 2 weeks ago, where there's breast cancer data actually, where they're trying to ask and try to figure out the same question. So on your left is real world evidence study of sequencing 2 ADCs, and on your right is the A3 study, which is a study that was presented in ASCO 2023 where they asked the same question. So in general, they have the ADC1 that they labeled and ADC2, and both are different. And in terms of the one on your right or your left, the sequence ADC real world evidence, they had ADC1 as sacituzumab govitecan. So it's basically to a TROP2, and it is a irinotecan payload versus TDXD that we have been talking about a lot today. And so you can see that the x-axis is the time on treatment. So you can see that those who had ADC1 actually had a longer time of treatment, so longer PFS, compared to when that patient then switched over to a second ADC, and it was a shorter. There are some patients you can see there that actually did benefit from ADC2 versus 1, so this really still highlights that these are generalizations and we need more data, but this is sort of these real-world study you can see. For A3 study, very similar findings. So those who are on the ADC1 actually had longer time on the ADC1 compared to the ADC2. So what does this mean? We think about the antibody, we think about the payload. Does it make a difference when you sequence which one actually might confer more resistance? So this is from the A3 study when they actually defined cross resistance. So the y-axis is the percent of cross resistance. And they define cross resistance as any progression on ADC2 by first restaging imaging or treatment time on the ADC2 less than 60 days. So you'll see that in the teal bar graphs, when patients had a change in the antibody, they actually had lower cross resistance compared to actually patients had the same antibody target and plus or minus a change in the payload. Suggesting that maybe the ADC, the change in the antibody, if you're going to do a sequencing, perhaps changing the antibody might actually have decreased cross resistance. So in terms of the key takeaways, there's strategic sequencing that we kind of went through in terms of NCCN approved ADCs based on indications and side effect profiles. These again are the NCCN approved ADCs for platinum sensitive, MIRV plus bevacizumab, folate receptor expressing tumors, platinum resistant, MIRV plus bev, as well as single agent MIRV for those 75% or greater, HER2 positive IHC2 plus 3 plus. And then while ADC is just really critical to monitor for adverse events, especially the ones that we are just not as accustomed to with chemotherapy and also actually immunotherapy, but just thinking about the ILDs, pneumonitis, and how they actually are specific to the ADCs in terms of when to actually discontinue for grade 1 pneumonitis, grade 2 pneumonitis. So really just involving your pulmonologist, continue the serial CT scans, and then really consider steroids. So thank you.
Thank you. All right, so there are microphones up, so we want you to ask some questions. I'm going to ask some questions until I see someone come up. But our goals for today, when we kind of got together as a faculty, was to try to put together, because the NCCN was just updated last month. So we wanted to make sure that we communicated the updates and why those updates came around with the addition of mirvetuximab, bevacizumab, and then trastuzumab deruxtecan. We wanted to make sure we talked about ocular toxicity. And I think we went through that pretty thoroughly. And we wanted to make sure we introduced the concept of pneumonitis screening, because a lot of us have never used trastuzumab deruxtecan, and we, maybe don't have close breast oncology friends, and they had a big learning curve around this asymptomatic, fluffy things on the CT in a patient who's responding and feels great. We're not looking to hold. So this is really the biggest pitfall for us. So I wanted to ask, so we would just work through this at our institution. So I wanted to see if Debbie would kind of take us through what we do for our deruxtecan payloads, and then I'm going to come over to Dr. Bookman.
Yeah, I mean, so I will tell you, when I get the CAT scan read, I mean, for one thing, just as a disclaimer, in Oklahoma, a lot of my patients have ground glass opacities or different changes because we live in a really windy state. It's flat, and there's a lot of storms and allergens. So that's a disclaimer. So what I have started doing is looking at the CAT scans myself. And then I usually pick up the phone and call one of the pulmonologists because I've gotten to know the two of them that really do all of this for us. And I usually look at it with them. But we halt the drug, we send the patient up home, we order the high resolution CT, although one of our radiologists would argue it doesn't make that big of a difference based on the imaging that they're already getting with normal CT. So just to kind of keep that in mind, you may not need that high resolution depending on how good your regular CAT scan is of your chest. But the PFTs can take a little while, et cetera. So we're just trying to do it all really fast. And then we put them in as urgent referrals, and they are where, especially when the patients are on trial, to get them in pretty quickly for us. So and talking to the patients about what the symptoms are to notify us for. And also, when we get a CAT scan that looks abnormal, I ask one of my nurses to call the patient and make sure nothing has changed, because even though you've told them before, sometimes they just forget, or they're like, well, I just thought it was allergies. And so you do kind of have to have a high degree of suspicion. And it's better to hold them for a short time and they don't have pneumonitis than to not hold them and they have pneumonitis and then end up with a bad thing. So I have started giving steroids for these grade 1s to try and help resolve it faster. And I was just talking to a few colleagues about a similar payload, and they're going straight to the 1 milligram per kilogram. The thing is, you don't have to wean them all the way down before you restart the drug. What you need to make sure is that it has resolved on the imaging. So it's not like IO where you have to get down to 10 milligrams of prednisone a day before you can resume. You can resume. And so they're actually, my pulmonologist is starting to wean them a little bit slower. So over every 2 weeks instead of every week, for example. So just to kind of keep in mind, you don't have to wean them real fast. I think those are probably like the big takeaways. And the other thing is that the patients that we have interrupted, for the most part, a lot of them are responding. So of course they're like scared to hold, but we've had to hold many patients and they are not progressing while we are working them up and holding them even for several months. And even the patients we pulled off, some of them we've pulled off and they had such a good response. We haven't even resumed any kind of therapy, and I'm just following them.
Dr. Bookman.
Yeah, thanks. Some instructive cases, and it's illustrates that it can be challenging to weave clinical guidelines, FDA marketing regulations and approvals with clinical care and science. I mean, they all work in slightly different ways. And so 2 quick points. One, with regard to the PARP inhibitor story and how the FDA indications were withdrawn for several of these agents in later stages of disease. That doesn't mean that you cannot use those drugs in appropriate settings in the appropriate patients. That is just a withdrawal of a marketing indication, and it doesn't prevent us as licensed providers from using drugs where we think they may have benefit for the patient. So I don't want people to feel that they cannot do things just because of that, because there are reasons why those events occurred, which have been discussed in other settings. I won't go into today in detail, but I mean, I think we shouldn't set aside our clinical judgment. That's an important point. The second is the first case that you had of interest. You were talking about platinum-resistant ovarian cancer, but it was a high-grade endometrioid cancer that you were presenting. And at this point, we know a lot more about the molecular biology of endometrial cancer than I think we know about ovarian cancer. And one can say that an endometrioid ovarian cancer is pretty much identical to an endometrioid cancer or an endometriosis associated endometrioid cancer involving the ovary, for example. So one option that wasn't up on any of the guidelines or any discussion was in a patient with resistant disease, lenvatinib pembrolizumab would be a consideration. And certainly there are patients in that setting that have responded well to that treatment. That was not included in the guidelines, and it was not included in the discussion. So just a couple of things to think about.
That's such a great point. Now I'm going to put it back in because I made for the ASCO update on Saturday. There was a presentation at ASCO for Len-Pem for recurrent ovarian out of Israel with, it was relatively small, but had really quite nice response rates as you would expect. And I took it out just because it was so long, but now I'm going to put it back in. I think you make a great point. People do bring that up.
Yeah.
And we talk about it in clear cell and endometrioid, as an option, but we don't put it up there because it's not in the guidelines. So I think that's
Yeah,
a
the
great
it's
point.
interesting, the guidelines don't get into histology at all.
No, not at
Yeah,
all.
that's I mean, I don't know if any guys.
They're
Are you,
actually-
you guys on?
So
the
there is some, I just didn't go into great
Yeah,
detail about it,
okay.
but they do actually call out mucinous.
Okay.
They
okay.
do call out clear cell.
And we have so much that we can
And
do
they-
for mucinous tumors,
And,
right?
and then they do call out low grade serous. So actually, like
Yeah,
if you look,
okay.
there's only so much time we can get into every little thing. But tamoxifen is actually not okay for low grade, but then it says on the, other useful
Yeah.
in other circumstances, that's where you're mostly going to find the cell type. But you're
Yeah,
right. I mean,
yeah.
it's not a huge difference when
Yeah,
it comes to epithelial. And to your point,
Yeah.
that whole FDA Dear Doctor letters
Yeah.
came out, and I had already had a patient who was platinum sensitive and on her platinum, and our plan had already been, she was contraindicated for Bev to go on a PARP maintenance. And guess what we did? I told her, here are what the Dear Doctor letters are. I don't really agree with the FDA thing. I documented in the chart. She's on PARP inhibitor maintenance. So
Sounds good.
it's just, I have to be careful when we have a lot of learners and things, and I have to stick to what.
Well, but
some
this is
degree-
part of the learning too. I mean,
Yeah.
being comfortable with good science and good clinical judgment is part of what we all need to do. But that's great.
Yeah.
Thanks.
Make sure.
Thank you very much, colleagues and friends, for that great presentation. I did just want to make a brief counterpoint to that like high-grade endometrioid ovarian versus low-grade ovarian endometrioid are definitely different demons, for lack of a better word, and that there is fairly good molecular data suggesting that high-grade endometrioid is very akin to high-grade serous versus the low-grade endometrioid. We debate this a lot at our pathology conference. But piggybacking on what Dr. Richardson said, I didn't see a lot there about time to subsequent therapy with the ADCs or duration of response. And again, this is totally anecdotal, but I also have a patient who went on mirvetuximab and tolerated 2 cycles. She tolerated it horribly, but she was a high folate response, had a very high FR score. And she's just been hanging out without any therapy and living her best life, which I'm super excited about. But I do wonder if there's something about that mechanism of action about the ADC that leads to a longer durable response afterwards, even if it's just that they're having partial response and then stable disease. And I'm wondering if any of you have either seen that anecdotally and or seen that in long-term clinical trial follow-up.
I think there's idea with the immune activation actually from the ADCs. So I don't think we actually have data where we actually been able to profile patients like tumors and actually look under the microscope, which I would love to do. But I think that might be some component for those who do respond well, like not on treatment because they're recovering. I have a patient like that too. And I think it might be immune related.
Yeah. I mean, I think we're just thinking of the patients we've had a DC for grade 1. One, it's been off for 8 months. And she just scanned and she's still like fine. One was off for 4 to 6 months before we restarted, and we put her back on trastuzumab deruxtecan actually at a dose reduction with care. So it is something that you stop them and you don't have to just put them on something else. You can kind of check it out for a bit, which I've never done. You've never done that. You're so fearful of stopping, and I've certainly been one of like push because I'm worried they're going to progress. And now I'm just like, let's just like see what happens. And you kind of win sometimes to just do less is more, but it's uncomfortable. It's uncomfortable. Yeah.
Thanks so much for your time today. This is maybe more of a thought or a reflection, especially since we're in the room with people who are like making trials. It's been a frustration, I think, for me in the past when we see the platinum resistant trials and you have a really promising agent and you're now coming into a comparative or a randomized trial. And even just the cases that you showed today where you're reusing bevacizumab, many times the control arm is like not an Aurelia arm. And that just makes it really hard for me as a clinician to I'll put this patient on trial, but I have an issue with the control arm. So I hope that as we continue to find more of these active agents and they come to randomized trials, that we have that flexibility, because we're seeing it even in the upfront settings now, Bev, at physician discretion, but I'm not seeing it as much in the platinum resistant setting. And I understand that it can be maybe statistically different or difficult or logistically difficult, but it needs to be kind of real world, especially if we want to do the best for our patients. I don't know if you guys have any thoughts on that or if you had a similar.
I love
Thoughts?
that you just said that. Like, I have so many feelings. I think that clinical equipoise means that the control arm needs to echo what we really would do. And no one has said we would use a single agent non-platinum for any of these patients. And that is probably the most important thing that anyone has said to me today. So thank you for saying that.
And I will say, I have to be a little careful, but now that I'm on the ASCO board, Dr. Pazder comes and speaks to us at the board. It's just fascinating to be with the FDA director and the NCI director at a meeting of 30 people. But he made exactly that point, not about GYN, of course, but just in general, that they are taking a much closer look at control arms on trials. And you just had some concerns about the fact that the best control arm isn't always included in clinical trials. So that was like just a few weeks ago, he made that comment, sort of, I think that will be reflective of pushback on clinical trial design moving forward. So just to let you know, it is what you just said was reflected back to me. Yes. Yeah.
On that, at your tumor boards for your 2+ HER2 patients, are you getting like a consensus we have to use trastuzumab deruxtecan, or are people going for the weekly Taxol? For the 2+ patients, is it like a slam dunk, or are you guys really wanting to see a randomized trial or a confirmatory trial? What are you doing?
So at our tumor board, we don't typically discuss our recurrence unless somebody requests it. We mostly just discuss our newly diagnosed. So a lot of those will come to Katie or myself. So in general at our site, like every patient who's progressing gets screened for trials. And we usually have trials. And so, then when I talk to them, I'll tell them what the standard of care options are, which would include whatever the NCCN guideline options are. And I would talk to the patient about both and what the side effect profiles are, et cetera, just like we do for any kind of chemo. And then hopefully we have a clinical trial that lines up with those things. And so a lot of our patients opt, like we've had a phase 1 of another antibody drug conjugate that targets HER2.
So you wouldn't be using, I can't even say
TDXD
in a 2+ recurrent.
I would if the patient didn't want to go on a trial, couldn't go on a trial. I have a patient on TDXD, but it's not, but the thing is, like, a lot of my patients go on trial.
Yeah.
So it's not maybe a fair thing for me to answer, but I have used it and for
Yeah.
2+.
I have used it for 2+ specifically to avoid giving Bev, so I didn't put somebody out who might end up getting a control arm where I couldn't use it again.
Okay.
Yeah.
So
I think that
it's
your
like
point
4
is-
steps ahead.
Yeah, go ahead,
Yeah.
Catherine. You go first.
Oh, no, I would lean towards TDXD first before chemo for the HER2 IC 2+. As long as they
2+, yeah.
don't have any of the underlying issues with the lungs or anything else that'd be of concern, and they understand sort of the risks or, some of the side effects that might come along with it.
Yeah, because I get even though Taxol or taxane Bev is going to work really well, there seems like there's a lot of negativity about putting patients on that regimen. Like in our tumor board, people don't love to go to that. Like that is last resort, even though it's super effective, which is why I think these trials that don't include it maybe for us are more real world, just as a devil's advocate kind of discussion. But anyway, thank you.
No, I think that Dan, you brought up a really good point. And that's one of the reasons we wanted to emphasize, even though we're talking about ADCs, we did want to emphasize the weekly paclitaxel data that's come out of the last 3 phase 3 studies, all of which were negative. And you're saving yours at ASCO. That was amazing. Your biomarker work for Excel. You.
Oh, yeah.
Yeah, but it was negative.
Oh.
I don't know, like, be too negative, but they're all negative. But I think all the patients actually benefited because they maybe went on weekly paclitaxel, whereas they might have been put on Doxil. Because I think what we see a lot of times is people going first to Doxil because it's every 28 days and they don't lose their hair, and there's no neuropathy, and patients don't want to lose their hair and they don't want neuropathy, and so we think it's equivalent, but it's actually far inferior. It's an inferior regimen. And so with cold caps and other things, weekly paclitaxel needs to be thought of in a different way. So we felt like it was important to emphasize that, because I think the phase 3 studies have brought that out. And we're out of time, but But you just hit on something that all of us have been talking about. And actually, I was on an international meeting for about 2 hours before I came down here talking just about what you brought up, is that we have these patients right now who are HER2 2+ and folate 2+, and maybe they're going to be TROP2 something, or maybe they're going to be cadherin 6 something, because there's tons of overlap, and you're going to be sitting there, and then you have weekly PAC. What's your best regimen for that patient at that time? And nobody knows. And that's a problem, I think, that we don't really know in a 2+, because I'm super on board with HER2 and we have a study. And so they all go on because we can go 1+ through 3+. So all of our patients go on that. And we've had a lot of benefit. But that's anecdote. And, if the Destiny data is correct to 2+, that's not any better than mirvetuximab. So maybe, and then the breast data, I would encourage you, and maybe you can use my sign in for ASCO, but the ADC talks that were given by Pat LaRusso for toxicity and Erica Hamilton for sequencing, if you're interested in sequencing and understanding the science, were kind of must watches. They're way too deep to like even encapsulate. But that's scary to me, because I always thought I was going to get to use like a bunch of ADCs. That was my view of the future. I'm going to use this one, and then I'm going to use this one, I'm going to use this one, and no one's going to lose their hair, and it's going to be this great thing. But now I need to think about it smarter, and I maybe need to use a different antibody. So I can't do maybe Profound Bio and Merv, because they're different payloads. I thought I could do that. Maybe I can't do that in ovarian. Maybe I'm going to need a different antibody, but I don't know this yet. And we're not doing the right studies to figure it out. So that's very frustrating, because I feel like we're going to be guessing.
But
Just
with
quick-
real world AI, we'll be able to go backwards and look
There you
at
go.
this
There you
in
go.
10 years.
10
Yeah.
years is too
10
long.
years.
Yeah, well, just what I've been able to use to justify the 1+ is the status trial, which was run by the National
Absolutely.
Cancer Institute in Japan and carcinosarcomas. And most of those are high-grade serous, just
Yeah.
with carcinoma differentiation. I mean,
With phenomenal responses, but
Yeah.
it was 10 patients.
still, I
But
mean,
still,
when you
I know,
put that,
but still.
Getting it.
no, but when you look at that in the larger context of the data,
Why
it
would
makes
you
sense.
use it?
And,
Yeah.
and there's never been a drug that had a response rate above 25% in carcinosarcoma.
Yeah.
That's had
100% agree.
a median of 4 prior treatment lines.
Yeah.
So yeah, I
100%
think it's
agree.
good.
Yep. All right. Well, we could talk about this all day, but we gotta let you go. Enjoy Seattle. Thank you so much.